everyone. So we'll go and get started on chapter 20. This is part two, even though the cover slide doesn't say it, this is part two. I think it's going to end up being three parts. So we'll keep going on gastro. So we'll finish with the gastrointestinal stuff, then we'll jump into some of the straight like renal disease issues, and then we kind of finish off with the third video will be like reproductive issues and kind of like the assessment treatment type stuff. So, all right, we'll keep going. So we can get these things. So we have the gallbladder. Where does the gallbladder sit? It sits in the right upper quadrant within the liver. I mean, if I could point that to myself right here, it's going to be like right about here. And so what happens is the the gall. Okay, let's talk about what the gall. We know what the gallbladder is. What is the gallbladder supposed to do? It stores bile. Okay, bile is made in the liver, and it is transported through these little ducts into the gallbladder. So the bladder, just like your urinary bladder, holds bile. Well, what does bile do? Bile gets dumped through these tracts, right? There's several tracts that it can go down and empty into the duodenum when your body senses that you just ate something with a lot of fat. And if you've ever made a vinaigrette and you've shaken up the vinaigrette and you suspended those fat droplets within a suspension, right? That's called emulsification. That's what bile does with our food. Is it takes big chunks of fat and it kind of shakes them up like in a vinaigrette, and it makes an emulsification, emulsifies it. So it makes big fat droplets into little fat droplets, so we can digest it a lot easier. Well, what happens is, and so I'll show you this. So bile is produced in the liver. It's stored in the gallbladder. It goes through these ducts, which aren't important to know the names of right now, and it through the pancreas even, and then it dumps right here into the second part of the duodenum. And so this is where a lot of like pancreatic enzymes, right? So the pancreas will produce stuff called like amylase and lipase and trypsinase and all these different stuff, or trypsinogen, excuse me, that will that helps like chemically digest food and break it down. And so what can happen is over time, for a variety of reasons, you can end up with actual stones like rocks, like pebbles, can build up inside the gallbladder. Well, a general pathology rule is when you get a stone that's stuck right here or even in here, the area back from that, right? So like say stone here. So that means all this area will get inflamed, right? So you can see this on a face with a pimple, or you can see this in appendicitis or whatever you want to think. But that's a general pathology rule that we've talked about. So what happens is in this scenario, you can get a stone that'll form in here for a variety of reasons. I'll tell you who gets these most often in a minute. And that creates pain. Well, when do they get the pain? When they eat something with fat in it. So the classical vignette is 44-year-old female, mother of two, eats tamales and refried beans at Christmas, and she has excruciating pain an hour after eating that, it presents with nausea, abdominal pain, diarrhea, whatever you want to call it, but they will say they have severe right upper quadrant pain. Why is that? Because what happens is as your body says, tamales and refried beans with copious amounts of fat are ingested, the body tells the gallbladder to squeeze down. Well, as it squeezes down, it's squeezing up against a stone, so that's very, very painful. Imagine that, like you're squeezing up against a stone, so it's going to cause pain. So that is that in itself is called cholelithiasis, right? And so, and I know they're talking about cholecystitis, but that itself, what I just described, is called cholelithiasis. Now, cholecystitis is when this becomes infected. Remember, cystitis, inflammation. When this becomes infected, right, or inflamed, that is called cholecystitis. Typically, it'll present with fever. It doesn't have to always, but it'll usually present with a fever with signs of like infection because it gets infected. So that is cholecystitis. So let's talk about who gets this. That's the same slide size as Cooper. Let's talk about who gets this. Who typically gets this is what they call the 4 Fs. Fat, so obese, females who are fertile because estrogen plays a role with this, and are over the age of 40. So it's called the 4 Fs. Fat, female, fertile, and over the age of 40. And so that's generally who you should watch for in a vignette if they tell you that, right? Like that's a pretty, that sounds like a cholecystitis. And so, again, typically it's after they eat something that's fatty. 30 minutes, an hour after they eat, and they will have excruciating abdominal pain because of this. Now, they will also have just general GI upset, nausea, vomiting. They could have indigestion, which is kind of like heartburn, bloating. They could be bloated, right? They could be gassy, excuse me, or belching. Okay, burping. So just be aware that this is a pathology that's called cholecystitis. Students get real hung up on that word. They're like, I've heard of this before, but I can't remember. Cholecystitis equals gallbladder. Okay, it's a gallbladder issue. So same thing. You could see cholelithiasis, choledocholithiasis, right? They all kind of mean the same thing. There's an issue with the gallbladder, usually related to a stone. So you ask yourself, what's the definitive treatment for this? It's sometimes you have to go in here and take the gallbladder out, actually. But that happens, electively, or sometimes if it gets really infected, like I said, it could rupture. If this ruptures, are you going to get peritonitis? Yes. There's a test called Murphy sign that you don't need to do, but I just want to make you aware. If you push on this area when they're breathing out, or wait, yeah, and you push in when they're breathing out, it hurts really bad. And so that's a general rule. Like generally, there's not a lot of liver pathology. There's not a lot of right upper quadrant pathology. The one that if you hear, I could put a blanket statement down. If you hear right upper quadrant pain, right, especially after eating, you need to think, oh, that's a gallbladder issue. That's cholecystitis. Okay. Now, as opposed to, there's something called pancreatitis. So we know the pancreas is both an endocrine and exocrine function. It sits pretty much where our stomach sits, right underneath it. And so the pancreas creates insulin and glucagon and somatostatin and all these digestive enzymes. And so remember the insulin, glucagon, somatostatin, those are endocrine, meaning they go straight into the blood vessels. But then we also have exocrine function of the pancreas, which is where the cells create their little juices and they dump into to ducts. And so they get ducted, like in an actual like duct or channel, down into the second part of the duodenum. And so what you end up with is, for a variety of reasons, this can get inflamed. Well, let me tell you this. The pancreas can break down a piece of steak or a baked potato or a big chunk of fat, right? And so the pancreas creates these really wicked enzymes, okay? Like I said, like amylase, lipase, right? Those are the bigger ones that you need to know or kind of be aware of. And so what can happen is the pancreas can auto-digest itself. It can self-digest itself. Because what is the pancreas made up of, right? Fats, carbohydrates, proteins, right? So if for a variety of reasons, the pancreas juices can start eating on itself. And as you can imagine, that's very, very, very painful. Well, the reason this becomes a problem, who gets this, right? Of course, I can demonstrate this. It's called choledocholithiasis, right? But this is when you get a big old gallbladder stone that gets lodged here. And if you get a big gallstone lodged here, where do all the pancreatic juices back up at? Right here in the pancreas. So it starts digesting itself. Okay, you could get a stone stuck here or here as well. But that's so gallbladder issues can cause pancreatitis. Also, it's classically associated with alcoholics. Okay, not my opinion. You will see this in alcoholics. It is also classically associated with people with high cholesterol, especially high triglycerides. Trauma can cause this as well. That's worth knowing. So someone could traumatically be induced with this. Those are the big ones. I put this out of one of my medical school books. It's probably a little bit overkill, but there's this mnemonic called "I get smashed," right? But a lot of times too, let me back up. This is what we call idiopathic. Remember idiots? They don't know. We just like an idiot, just uninformed you. They don't know, right? So idiopathic means we don't know what's causing the pathology, right? So idiopathic. So sometimes it just happens in people. Now, this can be remarkably fatal. I do know why, but it's surprisingly fatal, incredibly painful, and it is guaranteed ICU admission, right? These are very sick patients when this happens. Now, how does this present? They can become septic, right? We talked about septic shock, a form of distributed shock. It could also bleed. It could become hemorrhagic, right? So either of those forms of shock can occur. But the signs and symptoms are kind of vague, except for something I'm about to tell you. Severe pain, often radiating pain. So the pancreas sits pretty much where your stomach sits, okay? And so what happens is when it bleeds, okay, so the pancreas is also, this is annoying, retroperitoneal and intraperitoneal, right? So it's in the peritoneum and it's also out of the peritoneal. So when this puppy bleeds, it creates a very specific set of signs and symptoms called Colin's and Grace-Turner sign. So you can end up with Colin's sign, which is bleeding around the periumbilical region, right? So you could see this described as bruising around the umbilicus or periumbilical ecchymosis, right? That's Colin's sign. You don't need to remember the name. But you can also have what's called Gray-Turner sign. So this is bleeding on the flank, which is the retroperitoneum, because remember the kidneys sit behind the peritoneum, and so it's in the retroperitoneum. So what you end up with is Colin's sign along with Gray-Turner sign. Now I will say this doesn't really happen in the real world like this, but on exams it does happen like this. This is a late finding. You're probably not going to see this in the pre-hospital environment, but again, on exams it does happen like this. And so that is the hallmark. And how I remember Gray-Turner sign is it's on the flank, which is kind of like the back right here. And so you got to turn her over to look at her back. So that's how I remember Gray-Turners, right? So that's how you would do that. That's how I remember that. But anyways, they'll have abdominal pain, severe nausea, vomiting, distension, tenderness, right? So they will have actual pain when you start palpating right in their epigastric region where their stomach's supposed to be, okay? This is very fatal, by the way. I mean, I said it earlier, but like this is a big deal when this happens, and it does happen. So watch out for the alcoholic with severe abdominal pain, nausea, vomiting. It's pancreatitis probably. Very painful. They will be complaining of 10 out of 10 pain, right? Think about it. Their pancreas is literally eating itself. You can imagine how painful that would be, right? It turns it into soap, like saponification, right? So like it's a big deal when this happens. Guaranteed going to the ICU. And God only gave us one pancreas, so when people destroy this over and over again, they end up having to take insulin, and they essentially will end up with diabetes for the rest of their life. It's a bad deal. So this is a very common condition. I've had this as a child. You see this a lot in children. It can and does happen in adults, though. So we have the appendix. Where does the appendix sit? It sits off the cecum. So remember, it goes duodenum, jejunum, ileum. The ileum dumps right here at the beginning of the large intestine, and this little pouch right here is called the cecum. Well, off the cecum is this little annoying guy called the appendix. The appendix is about the size of a patient's pinky. And the annoying thing about the appendix is in pictures, it always points down, right? But in real life, it could go this way, or it could be pointed that way, or this way, or this way. So it can go in any direction. It's just like this little flappy valve. And this is a structure that we don't use anymore. You know, they think it's the equivalent of like a gizzard in a chicken where it was used when we digest a lot more grass, but it's not used anymore. So we don't need this to live. But what happens is, as you dump your Taco Bell chyme into, or your piece of corn, excuse me, into the cecum, the large intestines, from the ileum to the cecum, what happens is you can get something called a fecalith, right? And a fecalith is a little chunk of poopy, like a little turd nugget. And what happens is it can get stuck up in the appendix. Just like in general pathology, when you get a blockage of a tube, you will get infection of the area distal to that tube, right? Or proximal to the blockage, right? So down here, you're going to end up with an infection. So this becomes swollen and infected. When it becomes infected, it presents with a set of signs and symptoms, and this is called appendicitis, quite literally meaning the appendix is inflamed. So who gets this? You see this a lot in children, right? Those less than 12 years old, like classically 5 to 12 years old, 12 to 15 years old, 5 to 15 years old, you will see this, right? This can and does happen in adults, okay? But what happens is they will have extreme, or they can have right lower quadrant pain, because remember, this is the patient's right. So the right lower quadrant holds the appendix. So it will become inflamed, okay? And it will create pain. So they will have what starts off as dull and diffuse pain in the right lower quadrant. So, for example, in a male, generally on your EMT exam, if they say the patient, if it's a male with right lower quadrant pain, you should be thinking this could be appendicitis, right? If it's a female of childbearing age with right lower quadrant pain, you should be thinking this is appendicitis or an ectopic pregnancy or ovarian cyst or ovarian torsion or something like that, okay? So it gets a lot more complicated when it's a female. But if they have dull, diffuse pain, they will have nausea, vomiting, and diarrhea. They will have anorexia, which means they won't want to eat, right? Fever, they can present with fever, they usually will, and chills. And remember that whole rebound tenderness thingy, right? So as you push down on that area, it will hurt, but as you let go, it will also hurt. There's a couple tests you can do as well that they don't mention here that are they're not very specific, but they help. It's a good indicator of peritonitis. What you can do is you can ask the patient to stand up This is the floor, right? The patient stand up on their tippy toes and bounce down onto their heels like this. So boom. And so what happens is you jolt down onto your heels, that transfers the energy up into your guts. And as your guts get jarred, remember in peritonitis, they don't like feeling those bumps. It hurts. Okay. The patient's bedbound, you can just pick up their leg and bang on their heel. If that hurts in their abdomen and not in their heel, you could think, oh, that's peritonitis. Like this sounds like appendicitis. If it's a kid, it's hard to get them to do this test sometimes. So you just ask them to jump up and down 5 times, right? And them jumping elicits pain in the right lower quadrant. You might think appendicitis. Again, these tests aren't very, very specific or sensitive, but they can help. Now, this is surgical. Almost always, virtually almost always, you have to go in here, a surgeon does, and remove it, okay? It's a pretty easy procedure. No, now, this can rupture, right? So as it gets infected, it can get bigger and bigger and bigger. It can blow up, like explode. And if it explodes, then you're leaking in all your poopy contents and pus into your peritoneum. And then you're going to end up with, I mean, that's a pretty big deal when that happens. You have to stay in the hospital for several days. Okay. So just be aware, appendicitis, right lower quadrant abdominal pain. Gastroenteritis, this is just a very broad term for like a bacterial or viral infection of the guts, okay? It's typically from contaminated food or water, right? So this can be from unsanitary conditions, someone wiped their butt and then made your food, contaminated drinking water, contaminated lettuce, right? Someone spread their poop all over the lettuce field, right? And now you ate it. So there's a lot of ways this happens. Doesn't happen. This happens more commonly, I should say, in underdeveloped countries, poor countries like Mexico, the Caribbean, Asia, Africa, places like that. Okay, so now it can also be caused by non-infectious conditions, right? So it can happen. You could just get gastroenteritis for other reasons, but it's typically caused by bacterial or viral things, and it's like a stomach bug, right? We've all had this. So diarrhea, and I love it when they call foul odor, or like I love it when they say foul odor of diarrhea, like it ever smells good, right? Or odorless. They can have abdominal cramping, nausea, vomiting, fever, anorexia. Remember, anorexia is not wanting to eat, and dehydration. Okay, so the big thing you have to worry about with this one is actually dehydration. We're going to talk about why here in a bit. What type of shock can present if someone has profound vomiting and diarrhea, right? It's a distributive shock, hemorrhagic shock, hypovolemic shock. It is hypovolemic shock. Remember, low volume, low volume shock. Okay. Now, moving forward, there's this thing called diverticulitis. And so what happens is, this is from a lack of fiber. So actually, since medical school, I take fiber every day because I don't eat near enough fruits and vegetables. And so what happens is, fibers, we don't really digest it very well. So what happens is it kind of like scrapes the walls of the colon and gets all the poopy out, right? And regulates like bowel movements. But what happens is as people age, right, they end up consuming less fiber and they become constipated, right? And so as you become constipated, the pressure within your colon will increase. Well, as it increases, think about this, it can build up enough pressure to where you can have outpouching, right? So instead of the colon just being like this, right? What happens, especially here in the sharp S turn of the sigmoid, remember this little S shape right here is called the sigmoid. So this most commonly happens in the sigmoid. What can happen here is in these sharp turns, it'll kind of pouch out, right? So now you end up with like a pouching, and that's what they're showing you here. It pouches out. And so the whole wall of the colon will pouch out. Not the whole wall, but a good chunk of it, actually. It's not a true diverticulum. And so what happens is it'll pouch out, and so as you can imagine, as this pouches out and a good old chunk of poopy gets stuck up into this wall, it can eventually become infected. And when it becomes infected, it becomes inflamed. And when it becomes inflamed, that's where you become from what this is called as diverticulosis, outpouching of the colonic wall, usually from constipation and low fiber intake in the sigmoid of the colon, usually. It converts itself to diverticulitis, which is where there's inflammation and infection. And so what happens is they become infected, right? So they get abdominal pain, where at traditionally it's left lower quadrant, right? Where else do we get left lower quadrant abdominal pain? Constipation. So these go together, right? Fever, malaise. Malaise is just kind of having like a meh attitude where you don't want to do anything. You feel weak, tired, don't want to do anything. Body aches, right? Chills, nausea, vomiting. Bleeding's rare, but it can happen. So this again becomes a hospitalization usually sometimes, where you have to give them antibiotics and you have to get, you have to clear them out. They have to poop to try to resolve this, and they need to increase their fiber intake. And when it's reaches the point of diverticulitis, it's actually a pretty big deal. So diverticulosis in itself is pretty common, but diverticulitis, it's not as common as you would think, but it does happen, and this is extremely painful. So where am I getting at with this? If they tell you 62-year-old female, right, so she's not of childbearing age, right, left lower quadrant abdominal pain with fever, right, has a history of constipation, boom, diverticulitis, okay? Now, can it present in other quadrants? It can. But I'm just letting you know the go-to on that area is going to be the sigmoid. Think about it, guys. If you're driving down a windy road, right, and you have to make an S-shaped curve, you can run off the road. And so what's happening is like the poop, it builds up pressure. That's a good place for it to push its way through the walls of and create that outpouching. So that's why that happens. There's an increased pressure there. Now, ulcerative colitis is part of a spectrum on irritable bowel disease. Okay, and so ulcerative colitis. It's inflammation of the colon really from the rectum up. Okay, so what happens is the wall of the rectum, it starts at the rectum, it can work its way up, but it starts at the rectum. It gets ulcers. It gets ulcers, right? So this is a normal rectum, by the way, right? And this is one with ulcerative colitis. You can appreciate if this was your rectum, how painful that would be, right? So, and it bleeds, right? So this happens. This happens to people quite often, actually. And so what happens is they'll end up with bloody diarrhea, and they can have joint and skin manifestations. That does happen. But they can have pretty severe abdominal pain, right? So this is going to be like rectal area type pain, lower abdominal pain, or left lower quadrant pain typically. And then so they could have fever and fatigue. But the big thing is they could even have shortness of breath depending on how much blood they're losing. They could be anemic, right? This is a chronic disease. It is very treatable with some medications, but it can flare up because of stress. So that's ulcerative colitis. And remember, this is on the spectrum of irritable bowel disease. Okay. The other irritable bowel disease, which it annoys me they didn't put these in order. All right, I'm going to come back to this one, is Crohn's disease. Crohn's disease is also part of irritable bowel disease. And so what happens is Crohn's disease is you get these granulomas, right, from mouth to anus. And so anywhere from the mouth all the way to the end of the highway at the anus, you can end up with these attacks, right? And Crohn's disease and ulcerative colitis are autoimmune conditions where the body attacks itself. And so what's happening in Crohn's disease is the body again attacks itself, and you'll end up with these almost like lesions or wounds, and they can be back to back, and basically it can happen anywhere. Again, from mouth, esophagus, stomach, intestines, colon, rectum, right? And so you end up with these lesions that are very painful. Well, again, these can bleed, so you could see hematochezia, melena. Abdominal pain can be anywhere. It's just worth knowing this, right? This also has a familial genetic component, but I don't have much more to add on that. Now let's talk about irritable bowel syndrome. So I just talked about irritable bowel disease, which is Crohn's disease and ulcerative colitis. Irritable bowel syndrome is different, okay? Irritable bowel syndrome is more of a psychiatric condition, okay? And so what happens in irritable bowel syndrome is they have abnormal bowel habits, okay? So this is just their bowels are irritated. So they can have, hypersensitivity to the bowel pain receptors. Their bowels can be overreactive, right? So as soon as they eat, like boom, like it just flies through their guts and they end up pooping, right? So that's one way this can happen. But it's also, it can be like, there's a connection to psych disorders with IBS. So, if you look at what I just described, all three of these, right? These are more neurogenic, like neuro issues. These are not ulcers and, like lesions, right? These are like sensitivity to pain, overreactive bowel, psychogenic component, right? So that's what I'm saying. It's a psychiatric, it's not my opinion, but it's a psychiatric condition. And so, irritable bowel syndrome it's very common in the Western world. I think it's mainly because of our diet that can cause this. And so where you end up with problems with IBS is it can interrupt people's lives for sure, where they have to be really careful what they eat. But one thing I'll give you a quick distinguishment with IBS is they don't poop at night, right? So like generally, right? This is a generality, okay? Don't come after me in the comment section, but generally in a test, they won't tell you. They'll tell you that the patient doesn't have accidents or night or wakes up at night to poop. As opposed to the patient with Crohn's disease or ulcerative colitis, they have no choice, right? They will wake up and poop in the middle of the night or poop themselves in the middle of the night. So just be aware that's kind of the difference between IBD, irritable bowel disease, and irritable bowel syndrome. Okay, there's a difference. Whoops. So that's that. All right, moving forward. Now we're jumping into the urinary system, and you're like, "Wow, Hunter, that didn't really cover the whole GI system." You're right, it didn't, but this is what they think is important, so that's what we covered. So the urinary system, right? So there's obviously it's on a spectrum. They can be very severe, it can be acute, it can be chronic, right? But usually our care in the pre-hospital environment is just supportive. So what you see a lot, you see this very, very often, is something called urinary tract infections. So a UTI or urinary tract infection is when the urinary tract becomes infected. And usually how this will happen almost always is bacteria. So the reason this happens a lot more common in women because the urethra in a woman, an inch maybe, it's not very long. Compared to the urethra in a male, it's very, very long, right? It has to go all the way from the bladder to the tip of the penis. So it takes a lot less effort for the bacteria to colonize in a woman's urethra than a man's urethra. Now, with that said, can men get UTIs? Yes, but women are much, much more likely to get a UTI compared to a male. So what happens is you get an infection, right? And so this can be for a variety of reasons, right? Like someone who's incontinent, right? Someone who uses a diaper, for example, who wipes from back to front, so they end up smearing poop or feces into their urethra, and then of course there's bacteria in your feces, and so boom, UTI. You can get this from sex, right? So if someone has sex and they don't urinate after, like a woman has sex and doesn't urinate after sex, right? Postcoital urination, much higher risk of getting a UTI. So women, after you have sex, if you want to reduce the risk of UTI, go pee, right? Very, very important to do that. Who else can get, those that have indwelling Foley catheters, right? Someone that has a tube that's draining the urine from their bladder, an indwelling Foley catheter, right? That's a super highway for all them bacteria to climb up that tube into your urethra and bladder. So the problem with UTIs is these are what's called an ascending infection. So the infection starts in the urethra, then the bladder, right? That's called cystitis. Then it can build up into the kidneys. That's called pyelonephritis, right? And it can abscess and all these other issues. So it's just worth knowing that a UTI, they're very common. And I should start with this. There should not be bacteria in urine normally, right? Ever. There shouldn't be. But when there is, it can colonize and it can create infection. Now, there are people that have bacteria in their urine that walk around with no problems. That does happen, especially old people. So just be aware this can lead to a very lethal condition called urosepsis. It's actually surprisingly lethal for this when this does happen, but it does happen. Now, again, a urinary tract infection will start at the urethra, bladder. So that's UTI. The bladder, when it gets inflamed, is called cystitis. When the kidneys get inflamed or infected, right, by the same bacteria, that's called pyelonephritis. Pyelonephritis. That's a kidney infection. Okay. Now, interestingly, the signs and symptoms on this are obvious, except for what I'm about to tell you. The hallmark of a UTI is painful urination, frequent urge to urinate, or difficulty urinating. Why is that? There's inflammation in the urethra. So, of course, it's going to hurt as you're passing urine through there, or it's going to be difficult, right, because of inflammation. But what's interesting, and the urine can be urine or foul smelling. It has a very distinct smell if you've ever smelt this. It can also have mucus or white blood cells in it. It can be real nasty looking. But what the hallmark of this, which is very interesting that I need y'all to know, this is very odd, but you will see this guaranteed, is altered mental status. For whatever reason, all the way down there, right? An infection down there will present with altered mental status. So I used to work in a nursing home in high school. And so the hallmark was when a patient would start presenting with an altered mental status, even without fever, UTIs usually don't have fever at first, okay? Again, these are very odd. It goes against the rules, right? You're like, well, Hunter, you said it's infection. It is infection, but it doesn't have fever, okay? And at first. And so if you have an old person that has a rather acute onset altered mental status, right? And you're like, oh, wow, Miss Agatha's not acting as normal as she used to. They run a urine test and they see if she has a UTI. And that's very commonly a cause. So with, you know, older patients, when they start acting weird, they start fighting you or misbehaving or being forgetful or aggressive or tearful or whatever. They have an alteration of their mental status. One of the top things on your list needs to be UTI because it's very, very common. Okay? Very common. If you were to walk into a nursing home right now, right, and there's 100 patients, 10 to 20 of them have UTIs right now. Not kidding, right? So it's very, very common to see this. So we see this a lot. And I would say probably 80% of them have bacteria in their urine, right? So it's you'll see this a lot, especially if they have catheters, like an indwelling Foley catheter. Now, kidney stones. We've talked about this. They originate in the renal pelvis, right? And I think there's my goober self. I forgot to put a picture on here, but it's in the renal pelvis, right? So if this is the kidney and here's the urethra or the ureter, excuse me, there's this thing called the renal pelvis, right? In this area that I'm about to highlight yellow is called the renal pelvis. So the stones start there, and they can be really big. You've seen pictures of that, or they can be really small. More commonly, they're small. And so what happens is these solid substances like calcium and phosphate and urolate and oxalate and all these weird things, magnesium, they crystallize and they create a stone, like an actual stone. And so, you know, who gets this? This is people that have like excessive like carbonated beverage, like Monsters, Mountain Dew type stuff. Certainly you can get this. People that are chronically dehydrated, it gives those stones a chance to precipitate and to collect, okay? And there's just also a genetic component. There's a lot of reasons you can get this, but how this will present is, you know, I'll tell you how it presents when the slide comes. But calcium stones are the most common, right? And these are the little ones. I've showed you a picture of these before. They're small. They just look like little pebbles. Okay, it's more common in men. There is a hereditary component, but it occurs for virtually any reason. But the patients are almost always in severe, excruciating pain. How does this pain present? It'll start in the flank and it will work its way down over the period of hours as the stone moves, and it can go down into the bladder. And then from the bladder, so that was the ureter that was pissed off in the back. And out of the bladder, it'll go through the urethra. And through the urethra, you'll end up dumping it into the toilet. Now, in men, that pain can be felt in the scrotum. So be aware that males that had flank pain that now have scrotal pain, it's probably a kidney stone. Okay? Now, the scrotum is the skin that holds the testicles. And so what you have to think about with this is the interesting thing about kidney stones is the patient will not sit still. So if you ever run a kidney stone patient, they squirm like a worm all over the stretcher. They will not get comfortable. They can't get comfortable because they're in that much pain. So the hallmark thing that you'll see is the patient who's complaining of back pain or like lower abdominal pain or scrotal pain who will not sit still, probably a kidney stone. It's a very hallmark of that. They're very, very uncomfortable. They cannot get comfortable. So they just squirm around trying to get like comfortable, but they can't do it. So that's a kidney stone. Very common. You'll see this. You may have had one, right? So the hope is that eventually it'll pass. Now, what you have to worry about is if this stone gets lodged here and it cannot move, it's too big, this can build up. And as this builds up, water builds up in the kidney, and that's called a condition called hydronephrosis. And so as the kidney fills up with water, it creates its own whole another list of problems. And that's called hydronephrosis. So acute kidney injury, this can happen for a variety of reasons. The most common one is lack of blood flow. So, it's a sudden decrease in kidney function. What causes this is usually the kidneys don't get enough blood flow. So when they don't get enough blood flow, they die. So remember, the kidney, the heart, and the lungs, the kidney, the heart, and the brain, very perfusion dependent. boy, do they require glucose and oxygen to keep all those pumps running. And when they don't get it, they die very quickly or fairly quickly. And so the kidneys, though, they aren't like the head where they're like, oh, hey, altered renal status, or they're not like the heart where it's like, oh, hey, chest pain. The kidneys just die and they don't really say a lot at the time being. So it's something that we tend to overlook. But an acute kidney injury, the common cause of this again, late shock, right? As we go into shock, the kidneys will die because they're not being perfused. And so as they die, what happens is toxins in the blood that they're normally excreting will build up. And as they build up, that creates its own issues, okay? So the patient will experience just straight up, generalized edema, right? Remember, edema is the medical word for swelling. Acid buildup. Remember, the kidneys help with pH regulation. As they failed, right, an acute kidney injury, right, the acid will build up in the blood. So they become acidotic, right? pH drops. So normal 7.35 to 7.45, they'll have a pH like 7.2, right? So they're acidic, okay? Higher level of waste products in the blood, right? Hyperkalemia, which is low, or high potassium, you know? So the problem is if you don't fix this, if it doesn't get treated, whatever's causing the acute kidney injury, they can end up with heart failure, hypertension, metabolic acidosis, end-stage renal disease, all these issues. So just be aware. Now, as opposed to what we see more often is something called chronic kidney disease. So chronic kidney disease is it's a progressive and irreversible inadequate kidney function. So who gets this? Diabetics, smokers, high blood pressure, but diabetics, they're at a huge risk of kidney disease, right? So I always tell my students, right, if you were to go into DaVita dialysis at the dialysis center, right, and be like, what are you in here for, right? They would be like hypertension and diabetes, hypertension, diabetes, right? Usually why they're there, right? These are older people that have to go to dialysis 3 days a week, right, to get their blood filtered because their kidneys have failed. And so, commonly when you hear chronic kidney disease, I want you to think, oh, they probably had diabetes or hypertension, high blood pressure. So it ends up messing up the vessels within the kidneys. And so, the kidney, this will cause systemic issues, swelling, right? And so it can also be caused by congenital disorders, right? Or prolonged pyelonephritis. This is more rare, but remember, pyelonephritis is infection of the kidneys or secondary to some effects of infections. Sure, that can happen. But again, end-stage renal disease, chronic kidney disease, those issues, it's more common really related to diabetes and high blood pressure. Now, because they get, well, and this, okay, we'll just keep going. So scarring occurs as nephrons of the kidney become damaged and cease to function. So what happens is, we'll just use pyelonephritis in this example because, diabetes and hypertension is more of a vascular issue, but we'll just straight up say pyelonephritis, which remember is infection of the kidney. So as the kidney's chronically infected, right, there's all these inflammatory cells going in there trying to go to war. And as they go to war, just like when we go to war in whatever country, we end up leaving a mess when we leave, right? So the same thing happens as this happens for a long time. So you end up with scarring, and the kidneys can regenerate as opposed to like the brain and the heart in adults. But the kidneys can regenerate to a point. They reach a point where they're like, oh my God, we've been under attack for like years, right? And so eventually they're just like, fine, we're just going to be scarred. We're not going to regen. We're just going to go to scar tissue. And so that's how that happens. Now, I'll read these to you, right? But the signs and symptoms of renal disease are very broad, right? This could mean a lot of things, right? So altered level of consciousness, seizures, coma, lethargy, nausea, headaches, cramps, signs of anemia. Anemia, remember, anemia means generally it means low red blood cells, okay? For whatever reason. Uremic frost, you'll see this is rare, but basically this patient's skin will look like it's frosty, like almost powdery like frost from urea, which is a nitrogen byproduct. So it builds up in the blood and it'll manifest itself on the skin. This can also lead to pericarditis, which they say here. So pale, cool, and moist skin. Jaundice, remember jaundice? That's yellowing of the skin. Edema, right? Muscle twitching. This is a potassium issue usually. Hypotension or hypertension, but usually hypotension. Tachycardia. Pericarditis, remember this is inflammation of the lining of the heart, the sac that surrounds the heart. It's relieved when the patient leans forward. And pulmonary edema. What lung sound does pulmonary edema make? Crackles or rails. Sounds like they're breathing underwater because they are. Now, End stage renal disease, again, these are the patients that have to go to dialysis, hemodialysis 3 days a week, right? So usually it's like a Monday, Wednesday, Friday, Tuesday, Thursday, or a Tuesday, Thursday, Saturday schedule. They go for like anywhere from 2 to 4 hours a day, right? So imagine for the rest of your life, 3 days a week, you absolutely have to go sit in a chair for 2 to 4 hours, and if you don't, you die. It's very sad. And so this happens a lot. This is very sad. Um, that patients live that way. So, you could get a renal transplant, but that's rare. Usually they just do dialysis. And so, the initial signs of end-stage renal disease, confusion, shortness of breath, peripheral edema, remember, so swelling of the periphery. They could get easy bruising, chest pain, bone pain. There's reasons why that happens. I won't bore you with why. As toxins accumulate, you can get what's called pruritus, which is it's a weird word, but this literally means itching. So they itch. Nausea and vomiting, muscle twitching, tremors, hallucination, right? But their skin it can become pale, cool, and moist edema. You remember that word uremic frost, right? This is as the urea will crystallize and on the skin, and it creates like this frosty appearance. But in the late stages, they'll get coma and death, right? So, we typically get called, we can get called for these things, right? So how does this present? You know, 55-year-old type 1 diabetic who missed the last two diabetic appointments and now she's unconscious and seizing, right? Like, of course, they have end stage renal disease and they're not taking care of business, so they're going to be in bad shape. We're going to pause here and then we will finish up the lecture with this last video.